Okay, our next speaker today is Dr. Tamara Nation, who is a general practitioner, medical educator, and public health advocate who has an interest in complex and chronic illness, especially in the area of women and children's health. Dr. Nation was taken on the journey of becoming a medicinal cannabis prescriber by patients who wanted the opportunity to trial medicinal cannabis in their treatment regime. She has over 4 years of experience as a cannabis clinician in Melbourne and both local and international training in the area, providing teaching for the next generation of medicinal cannabis doctors in Australia. Please welcome Dr. Tamara Nation, whose presentation today is titled Medicinal Cannabis and Drug-Drug Interactions. Welcome.
Right, I'm just going to look for the clicker. So thank you all for coming today, and it's wonderful to see so many friends in the audience. It's certainly been a massive journey since medicinal cannabis became legal in Australia. Firstly, in terms of conflicts of interest, I have no conflicts of interest. I have provided talks and case studies in the past. Currently, I do most of my education with the Society of Cannabis Clinicians Australian chapter, which is an amazing group of doctors, all whose mission statement is to provide high quality, independent education to the next generation of cannabis prescribers in Australia. In terms of my medical practice, so I work as a community GP. I also work in a specialist integrative medical clinic. And what took me on this journey? So as Helen rightly said, in my community medical practice, there was a patient who I knew who had metastatic breast cancer. And she disclosed to me at the end of a consultation that she'd tried illicit black market marijuana. It had provided her really good pain relief. And she grabbed my hand as she was leaving the room and said, "Tamara, can you prescribe me medicinal cannabis?" Until that point, and it's now roughly 6 years ago, medicinal cannabis was certainly not on my radar. I had no plans of being a prescriber, but because of my patient, and I knew that at the National Institute there was soon going to be an education program, I decided to do it, and that led me on this journey. So in terms of the utilisation of medicinal cannabis and what I've seen over the past 6 years, it's been massive. And as everyone who's been attending the symposium, been presenting at this symposium has described, there's been a massive change in the number of applications, the number of prescriptions being made. Yet, as most would argue, this still is not enough. I've also seen the evolution of cannabis medicines in Australia. I remember starting 6 years ago and there were 2 or 3 that I could apply for under the Special Access Scheme. But today, there's so many. It's in the tens, potentially even hundreds. Similarly, the number of cannabis prescribers has changed. So when I started, I was a suburban general practitioner with a special interest practice. And all of a sudden, today we see a massive growth in terms of telemedicine, in terms of specialist cannabis clinics. It really is a national encompassing area where you see doctors prescribing for patients in multiple different states. My particular practice, the majority of my patients I see face to face, so it's very local. And on top of all of this, soon to be S3. So here we have, in such a short period of time, seen a couple of medications turn into 10s to 100 or so medications. From a typical doctor that you see in their clinical practice, we've seen it evolve into a national scheme where people are prescribing all over the country, dispensaries are dispensing all over the country, and very soon the landscape will change again, where we see medications, CBD medications, available over the counter for consumers. So it comes to ask the question, with increased frequency of use, are there risks that both clinicians and consumers need to have greater awareness of? So there's the obvious contraindications, things like psychotic illnesses, schizophrenia, unstable cardiovascular disease, poor liver function, end-stage renal disease, pregnant and breastfeeding. But is there anything else that we also need to consider in this scope, in what to be mindful of? And this is where I'd like to discuss medications and medication interactions. Now, there's the usual medication interactions that we're all aware of, things like benzodiazepines for epilepsy, warfarin doses in terms of INR and monitoring. But what else? Is there anything else that we should consider? What do we need to know to safely prescribe or use medicinal cannabis? And it's about educating ourselves, both as practitioners and as consumers, so that we can fasten our seatbelts on this ride, which has started and it seems to be going ahead at lightning speed, more so than I've ever seen with other medications during my time as a medical practitioner. So it's important to know how medicinal cannabis is metabolized, and that's by the cytochrome P450 superfamily of enzymes, which play a key role in the metabolism of drugs and other xenobiotics. And within this, you can see it's quite complex. CBD is metabolized by the CYP1A2s, 2B6s, 2C8s, 2C9s, 2E1s, and a couple of others. THC is also metabolized by a range. CYP2D6 is inhibited by CBD and THC. CYP, 2C8, 2C9 and 3A4 are inhibited by CBD. And on top of all of this, CBD may potentiate THC by inhibiting its metabolism. And we all know cannabinoid medicine is complex. And here we are just talking about CBD and THC. What about all the other cannabinoids? What about the terpenes? This is an extraordinarily complex area of medicine that we are just scratching the surface of. So my question to you is, can doctors predict who should take certain medications and who will suffer side effects? With personalised medicine, physicians may be able to use genetic profiles to make treatment choices. And for me as a clinician, medicinal cannabis has been extraordinary because it has been able to give me the opportunity to prescribe very precise medication to my patients in micro-dosing amounts, as Judith said earlier, with careful monitoring, getting it just right for that individual. Not a fixed dose, not off a pharmacy shelf, but personalised, individualised, tailored medication. So we look at this extract from the European Journal of Drug and Metabolism and Pharmacokinetics. Although the application of medical marijuana and cannabinoid drugs is controversial, it is a part of modern-day medicine. The list of diseases in which cannabinoids are promoted as a treatment is constantly expanding. Cases of significant improvement in patients with a very poor prognosis of glioma or epilepsy have already been described. However, the occurrence of side effects is still difficult to estimate, and the current knowledge of the therapeutic effects of cannabinoids is still insufficient. In our opinion, the answers to many questions and concerns regarding the medical use of cannabis can be provided by pharmacogenetics. Knowledge based on proteins and molecules involved in the transport, action, and metabolism of cannabinoids in the human organism leads us to predict candidate genes which variations are responsible for the presence of the therapeutic and side effects of medical marijuana and cannabinoid-based drugs. And this can be further divided into receptor genes, transporter genes, bioactivation genes, and the list goes on. So, as they say, knowledge is power. And having an understanding of your own pharmacogenetic profile regarding medications can provide powerful insights into what will exactly work for you. And this is something that I've not had to do with other medications most commonly prescribed on the PBS, although in saying that, a lot of medications which are involved in mental health, it is good to double check on. But medicinal cannabis, more so than others, gives us scope to explore this space. So certainly, it's not possible for everyone to find out their genetic profile. But when is knowing more important than not? I think in patients who are known or are most likely to have mutations, maybe they've had multiple adverse effects to multiple drugs in the past. And the other group is the at-risk population. So those at extremes of age, those who are vulnerable in our community, people who have communication issues, people who experience mental health conditions, all of these groups, it would be worthwhile having an understanding. And I'm actually quite delighted to see Ian McGregor here, because this sort of sparks a conversation around understanding how science can inform clinical application and clinical application can inform science. So I'm going to share with you a clinical experience that I had when I prescribed some patients, but there's in particular one, a CBD dominant product. And for my good fortune, I knew Ian, I knew his team at the Lambert Institute, and this was terrific. They had recently done a publication that predicted that there was not a significant likelihood of an interaction between fluoxetine and CBD, as it had little effect on the CYP2D6 metabolic pathway, which is one of the key metabolic pathways in the breakdown of fluoxetine. And this was done by a very talented postdoc, Lindsay Anderson. So I presented a case to them whereby I had a patient who had a significant adverse reaction to a very low dose of CBD, and they were also on fluoxetine. Interestingly, or importantly, I had available their cytochrome P450 enzyme genetic profile. And the finding was that in this particular case, there was a mutation in the C2D6 pathway, and therefore potentially fluoxetine was being metabolized by CYP2C9, so an alternative pathway, and this may have had an impact because CBD may have affected its metabolism. So to go into more detail about the case, I'd like to present it to you. A 17-year-old male who has a past history of nonverbal autism, ADHD, OCD. He was on multiple medications, including clonidine, fluoxetine, and risperidone. He'd previously tried other medications such as dexamphetamines and had side effects. And when he presented to me, he had symptoms of agitation, anxiety, repetitive behaviours, and hyperactivity. So after significant discussion with his carers, his parents, informed consent was done, and the decision was made to trial a CB dominant product, carefully up titrating him. However, 2 weeks after the patient commenced treatment, adverse reactions were reported. There was insomnia, increases in agitation, hyperactivity, vocal yelling, and worsening of his OCD. And certainly this disrupted his life as well as his family, who were just frantic. Therefore, CBD was discontinued. And the finding was that he had this mutation. And the thought process was, would there potentially, therefore, have been an interaction with the SIPs, with fluoxetine, and with CBD. And the question for me as a clinician was, had I known this previously, would I have done anything differently? So in this case, I didn't have his genetic profile till afterwards when I asked his mum and dad to please do the test, because I wanted to see if there was something which could be linking it, and therefore was able to present the data to the scientists. The next case that I want to present is a similar sort of case in terms of another vulnerable population group. So 24-year-old male, past history of non-verbal autism, epilepsy, lives with his parents. His medications included valproate, BD. His last seizure was 2 years ago. When he came and saw me, he had behavioural symptoms of autism, agitation, refusal to leave the house, aggressive and violent towards his mum. And he was refusing SSRIs and antipsychotics. Henceforth, he was eligible for a trial of CBD. And again, the decision was made to do a whole plant extract, CBD dominant, and very low dose. So 3 milligrams, carefully up titrated to 12 milligrams. But yet again, another adverse reaction. I was contacted by his mother at the dose of somewhere between 9 to 12 milligrams of CBD. So very low, especially in the context of, a S3 drug up to 150 milligrams per day. That his behaviour had deteriorated also. He was not sleeping well, he'd had an increase in his OCD tendencies in terms of his food behaviour, constantly taking off and putting on clothes. And so the decision was made to cease his CBD. And again, I did a SIP analysis, and there were some enzymes which were intermediate in function, some enzymes which were normal. And they were also involved in medicinal cannabis production or synthesis and metabolism. And what my hypothesis for this case was on my own was that potentially valproate had an inhibitory effect on CYP2C9, and CBD had an inhibitory effect on CYP2C9 as well at the same time. So although the valproate was being used for epilepsy management, we all know it's also a mood stabilizer. So could there have been a drug-to-drug interaction? And in retrospect, should I have done things differently? So it did make me wonder, and if I was to do things differently again, what would I have done? Well, I would potentially have chosen an isolate versus a whole plant extract, because as we know, the entourage effect is not likely to occur with an isolate, so very carefully dose up titrated with a purified CBD product. Would I have not gone down the space of starting medicinal cannabis for this case in the first place? Or would I have consented mum to a significant reaction which might have affected his sleep incredibly and his behaviour incredibly? So, as you can see, as we prescribe medicinal cannabis, it's a learning curve, both for us as clinicians as well as for our patients. And this has made it such a good therapy to participate in, because it really means that you're working together as a team to find the best fit for the individual. So in this case now, I present to you a 21-year-old lady who had chronic pain secondary to fibromyalgia. She had a past history of anxiety and depression, postural orthostatic tachycardia syndrome, chronic fatigue syndrome, bipolar affective disorder. And again, she was on multiple medications: oxycodone, the combined oral contraceptive pill, meloxicam, which is an anti-inflammatory, paracetamol, codeine, tapentadol, duloxetine, quetiapine. And she came to see me for pain. And the decision was made, becoming super cautious, we'll just try CBD, a CBD dominant product, but when I tried that, that had little effect on her pain, but some improvement on her mood. So the decision was then made to change her formulation to a one-to-one product. And I carefully gave her a very small dose of 0.25 mils BD, so about 2.5 milligrams of THC, and the patient reported good therapeutic efficacy. Then all of a sudden, she came to see me on a review appointment and said it was no longer working. And this is, over a space of 6 months getting treatment right. And so she wasn't on it for a great period of time. Interestingly, I found that the patient had commenced on olanzapine, and previously she'd been on quetiapine. As she was a really complex case, we reviewed her CYP450 DNA, and there was an abnormality finding that she was an ultra-rapid metabolizer of the CYP1A2 system. And interestingly, this metabolized both olanzapine and CBD. So the question that I have as a clinician is, could there have been a drug CYP450 enzyme reaction which reduced the efficacy of the cannabis when the olanzapine was introduced? The decision was made to increase her dose of THC to 5 milligrams BD, and her medication was also changed. I wrote a letter to her psychiatrist, and she was changed from olanzapine to lamotrigine, which has a different metabolic pathway. Importantly, what was the outcome? The patient's pain improved, her pain severity score and interference scores improved, and we were able to deprescribe tapentadol and codeine. So in conclusion, what does this all mean? Well, I think the medicinal cannabis industry is certainly an industry in a monumental growth phase, and it is an absolute privilege to see you all here today. I remember when I started out, I'd have to go overseas to access a conference of this calibre. But it's still important to understand that it's a relatively new Australian medication. It's new for us as prescribers in our treatment sphere, and it soon will be new for you as consumers as you access more and more S3 scheduled drugs. And with this, there's a lot of independence and empowerment, which as a clinician, I'm all for. I think if a patient, if a consumer can manage their complex chronic illness, then their chances of success are far greater than if it's with a clinician who's at the end of a prescription. But with this, I think we all have a duty of responsibility and care. So it's terrific that we're all here today and able to discuss this topic and potentially have greater awareness for those vulnerable populations whereby, although CBD may provide great benefit, there's also the risk of significant adverse effects, which we all need to be aware of. So I'd like to thank you all for your time, and if you would like to contact me, feel free at any point.